Welcome everyone to this community talk in which we will discuss a research project between the University of Ghent and the Catholic University of Bukavu. We will start with a small introduction video to set the context, and afterwards we will give the floor to Professor Joris de Lange and Professor Justin Chikomola. Together, we will discover more about the research on diagnosing and monitoring diabetes in the context of the Democratic Republic of Congo. Before we start, two small announcements. So throughout the presentation, feel free to already raise your questions in the chat. And then afterwards, we will also have a lot of room to discuss them directly with the researchers. On a second announcement, this community talk is being recorded so that we can share them on our YouTube channels for people to watch it or rewatch it. Please be aware of that. So without further ado, let's dig in. And yeah, we hope you enjoy this community talk. Share my screen.
In Democratic Republic of Congo, rural areas face with difficulty for glucose measurement by lack of equipment such as spectrophotometer. Besides, transportation of blood glucose samples from rural area to district hospital is hampered by road conditions, as you can see in this video. Unfortunately, the delay in blood measurement leads to the loss of 10 milligrams per deciliter per hour of blood glucose concentration. Glycated nail proteins is a new marker developed to overcome these conditions. Since it's cheaper, simple, and doesn't allow any blood glucose prelevation. For diabetes diagnosis, patients give nail clipping as small as possible. 10 milligrams of nail clipping is sufficient to perform glycated nail proteins. So, glycated protein in nail, also called fructosamine, react with nitroblue-tetrazolium region to give pink color, which absorbance is proportional to fructosamine concentration in spectrophotometer.
So I would like to give the floor to Professor Joris de Lange and Professor Justin Chikomola.
Okay, so thank you very much. So as you have seen in the video, the analysis of human body fluids, such as blood, is extremely difficult in the setting of the Democratic Republic of Congo. Transportation is a nightmare, and moreover, we have to face a psychological threshold as many people, in particular in rural areas, they do not like at all that blood is taken from them. So we were facing a huge problem. And during discussions we had amongst the Congolese and Belgian colleagues, we decided to explore the possibilities of using nail clippings as an alternative diagnosis for the diagnosis of diabetes. Since nail clippings, they are mainly consisting of proteins, and these proteins are in very close contact with our blood vessels. Hence, our fingernails have a pinkish color due to this intense contact. And we were considering the possibility that the information that is present in a patient's blood, namely the glucose level, would be translated in an increased glycation, addition of blood glucose to the fingernail proteins, and so we could come to an analytical system which allows us to test for diabetes. Nail clippings, in contrast to human body fluids, are extremely stable. You can store them for weeks and for months. And this is, of course, they're easy to transport. You don't need any refrigerator. So this looked at first sight a worldwide study project. And so two of our Congolese colleagues, Antoine Kishabongo and Justin Sikomola, have elaborated on this and have worked out a system which proved out to be workable even under difficult circumstances. And we will go through together with you the various aspects of this project. So we can see in the next slide. Yes. So although diabetes is considered as a Western problem, and at the time being, there is still a majority of diabetics living in developed countries, Europe, North America. But this is changing. We see that worldwide, the relative amount of diabetics is rapidly growing in developing countries. And moreover, we have to realize that the diabetics that are seen by our colleagues in the DRC are not the same as the one in Belgium, and I think Professor Sikomola will comment on this very soon. And from a European perspective, it is easy to diagnose diabetes because of glucose levels, but they are unstable. So every hour you lose during transport means a loss of 10 milligrams per deciliter. So finally, when your transportation is bad, you will finally lose your diagnosis. Of course, people at the WHO in Geneva, they think, oh, we have an alternative. We can use hemoglobin A1C. But they forget that in Africa, 70% of the abnormal hemoglobins of the on this planet are found. This means that apart from being very expensive, hemoglobin A1C is not always interpretable. So I will give the word to Professor Sikomola to explain how his diabetics are different from the ones I see. For me, the world is rather simple. There are only diabetics type 1 and type 2. But in the DRC, this is not the case. Please, can you comment, Professor Sikomola?
Thank you very much, and thank you for having me in this podcast. Of course, yes, what we have been seeing in Europe, or when I was studying endocrinology, I used to have two types of diabetes, type 1 and type 2. And then when I come back in Africa, starting working, giving care to patients, I realized that it is not as simple as I saw in Europe. First, talking about type 1 diabetes, most of these populations are developing their diabetes very later if I compare to people in Europe. But for type 2 diabetes, it's more complicated because we have first, most of these populations are developing the diabetes very, very soon, around 25 years. It is the mean of the age of developing of this kind of diabetes. Secondly, we can find among these people a few number of those who are obese. We can have a big number of people having type 2 diabetes without being without being obese. Also, we have another particular form of diabetes we used to call the ketosis-prone type 2 diabetes, which is very, very common in Africa. In that sense, what we have as recommendation in treating diabetes, even in screening diabetes, these recommendations are not adapted for Africa. Because when we come to choose the medicine we give to patients, it's complicated as we have not a huge number of obese. That's why we use to give some different recommendation to treat type 2 diabetes. Professor Delang told about the hemoglobin, and this is the big issue when we have to follow patients with diabetes. I'm not sure that when I have to say this is a good control of the disease, if I have to consider the A1C, most of these patients are suffering from malaria. We know that malaria can bring to hemolysis and many other hemoglobinopathies, and I'm not able to make sure that I'm trying to have a good control of my patient. That's why I think for Africa, it is important to find another way to control type 2 diabetes, another way even to diagnose type 2 diabetes if we consider all these particularities of diabetes in Africa. Thank you. Here we can see what are the recommendations to the international recommendation for the diabetes diagnosis. The fasting plus glucose. I think Professor Delang shared the limits of this, and in Africa we are not able, as we have many problems with laboratory, they are not really occupied. So we use the point of care to diagnose type 2 diabetes, and this is not the national recommendation. This is the same for the oral glucose tolerance test. And I gave it some topic about the hemoglobin, glycated hemoglobin. If we have many limits of this one. The slide, please. So if we consider all of these, the problem of pre-analytical stability of glycemia, the hemoglobinopathies, and the cost of this test, the economic aspect, accessibility to sophisticated equipment. So all of these bring us to think about another way to test and to follow patients with type 2 or type 1 diabetes. And I will let Professor Delang to go through the methodology and the technique of what we developed and for people to understand what we are working on. Thank you.
Okay, so as already discussed, the pre-analytical issues are really problematic. And to give a typical figure, when we are sampling in the village of Walungu, it takes us over 3.5 hours to get the sample to the central laboratory in Bukavu, although it's only 15 kilometers away. So Yes, we can see on the next slide, yes, that measuring hemoglobin A1C would be a theoretical alternative. This is what WHO is proposing, but we see that in Africa there are so many hemoglobinopathies that interpretation of this expensive test is far from easy. Moreover, one shouldn't underestimate the costs of point-of-care testing for hemoglobin A1C. Professor Sikomola already pointed out that due to the low numbers, people are often obliged to switch to point-of-care testing, which means that there is no control of the result in terms of hemoglobinopathy. And on the other hand, there is a problem with the pricing. This may cost $15 for one single test, only for diagnosis, which is a considerable part of the income. People have to work 2 weeks in order just to be able to buy one single diagnostic test. So we were looking for alternatives. So yes, next slide, with our 2 Congolese PhD students at the time, Antoine Kishabongo and Justin Shikomola, we have started working on an African alternative. Next slide. And here we go to the basic chemistry of diabetes. Diabetes is not, although it's a primary problem created by excessive concentrations of glucose, the long-term effects of diabetes are mainly due to non-enzymatic glycation of proteins. This reaction will finally cause the side effects of diabetes, such as nephropathy, such as retinopathy, and atherosclerosis. This is based on a non-enzymatic reaction of the lysine groups of the proteins with the glucose. This is called the Maillard reaction. And this Maillard reaction is the basis of hemoglobin A1C formation. But there is, of course, a more universal character of this Maillard reaction. Next slide. Yes, we see that our nails are in close contact with a capillary bed, which means a network of capillary vessels. And we know that these nails grow very slowly. It takes weeks and weeks to grow a nail from proximal to distal. And in the meantime, the information about the glucose is transferred into the glycation reaction, the Maillard reaction in the nail. And if we clip the nail at the end, we obtain nicely the information that has been accumulated during the last weeks. The question is, how can we do it? Well, that's rather easy. We simply are taking the glucose out of the nail by a chemical reaction, which is the fructosamine reaction. So we continue, and we see how the nail is containing many keratins, and these keratins are used to participate in this reaction with nitro blue tetrazolium. It's a well-known chemical reaction, and it is carried out usually in serum, but we decided to carry it out in nail clippings. Next slide. And we see indeed this is a very simple laboratory configuration. We only need a nail clipper and the nail clippings, and we can use this for analysis. Here you see that we have tried to grind the nails, but it is not necessary in the chemical test. Yes, we can continue. And yes, this is the reaction. So chemically speaking, the formed fructosamine will react with a dye, nitro blue tetrazolium, which changes into color, into a reddish colored formazan compound. And this can easily be detected in a photometer at a wavelength of 530 nanometers. This means that many African district hospital laboratories are able to carry out the reaction without buying sophisticated machines. The reagent is also extremely simple to prepare and can easily be prepared in the African district laboratories. So it is an extremely cheap alternative, and we don't need to purchase expensive equipment. Next slide. Of course, the reaction in the nail is a little bit slower than the one we are used to in the cuvette when we are measuring serum. And we see that within 1 hour, we see a nice development of the reddish color. So this allows us to monitor the degree of the diabetes. Next slide. And of course, you can argue, yes, what is the relevance of a nail? Okay, nails are not considered to be relevant organs from a clinical point of view, but at the same time, we have analyzed surgery material originating from people who underwent cataract surgery. And we have analyzed, using exact the same analytical principle, the glycation of the eye lens fragments, which were obtained by phacoemulsification. Of course, this was a medically indicated operation. To our own surprise, we saw a very good correlation between the glycation occurring in the eye lens and the glycation occurring in the nail. So in other words, what we measure in the nail is representative for the lens. Of course, it's much easier to obtain nail clippings than obtain lens fragments. Next slide. And this is what you see. So in parallel, for instance, you see the diabetic reaction, and on your left-hand side, you see yellowish lens, which is affected by the Maillard reaction. You see this yellowish-brownish coloration of the lens, which is caused to the Maillard reaction, is exactly the same what we are measuring in the nail clipping. Next slide. Yeah, we see that is the big disappointment. You would expect that the correlation between the nail clippings and the hemoglobin A1C would be excellent. This is not really true. There is only weak correlation. Why is this? Because the time window that is examined by hemoglobin A1C is different. And secondly, hemoglobin A1C is a very atypical representative of the Maillard reaction, since it is measuring the terminal valine residue. And we have to realize that it is rather exceptional, since everywhere else in the body, it is the lysine that is catching the glucose residues. And in the case of lysine, human beings usually have a deglycation mechanism. So in other words, we measure the the net result between glycation and deglycation, which is also the case in real patients. So I do believe that we are measuring a process which is closer to clinical reality than hemoglobin A1C. Next slide. So we see indeed that hemoglobin A1C, this is known in literature, this is referred to as the glycation gap, which is nothing but the difference between the fructosamine-based approach of glycation and the A1C-based approach of glycation, that there is a difference. And this might explain the reason why we don't find a perfect correlation with the A1C method. Next slide. So this is, in a nutshell, the difference between the formation of hemoglobin A1C, which is only investigating the arrow from left to right in chemical terms, whereas the lysine-linked glycation, that's what we are measuring with our nail approach, is actually measuring not only the arrow from left to right, but also the reverse reaction, the deglycation. And this is more representative as we see. Okay, so that's the theory. Now we are going to the practice. So we do apply this reaction in the Hôpital Provincial Général de Référence de Bukavu. You see the main entrance of the hospital is Dr. Kishabongo entering the hospital. You see the waiting room of the hospital, and to your right-hand side, you see the nail clipping, which is well accepted psychologically. I think Professor Sikomola, you can add something about the acceptance of the nail clipping procedures versus conventional blood drawing by the local population.
Yes, thank you. I think it is clear that it's very easy to give nails than to receive a point for giving blood. And more than that, I can imagine people, for colleagues who are used to vaccinate patients, they know how it's very easy to giving vaccine, oral vaccine, that to have to receive some point for to have vaccine. So it is very easy to give nails. Patient can come themselves with nails from home. We don't need many instruments to have nails. It's very easy, and people are very happy to be treated considering this method. I saw just a question about children, and I just have to mention that in the study we include also type 1 diabetes, and it's worked very hard for them. Thank you.
Okay, we continue. Yes, here you see the practical representation of the work. So you only need an analytical balance in order to weigh the amount of nail clipping. And this on your left-hand side. And right, you see the simple photometer. The reagent is prepared locally, so it's a low-cost reagent. And the photometer, which is a standard equipment of most African district laboratories, allows us to obtain quantitative readings. Next slide. So we did assess glycated nail proteins in the Congolese population. And we had a particular interest for pregnant women who are often characterized by an unstable type of diabetes. So in this group of patients, we have simultaneously measured A1C, glycemia, and glycated nil proteins, and we followed up the patients during 6 months. Next slide. And we see indeed, if you compare the three markers, glycemia, A1C, and the glycated keratin, so in other words, the nail clipping, you see that the reduction is quite spectacular. So it is a clinically useful and a clear signal that we can indeed monitor, not only diagnose, but also monitor diabetes in Congolese diabetes patients at a very affordable price, much cheaper as compared to, for instance, hemoglobin A1C. Next slide. So theoretically, you can get rid of the chemical reaction. We have seen that the chemical reaction is a little bit time-consuming. It costs us about 45 minutes to get a full development of color. So we can get a much faster procedure, but therefore we need a spectrophotometer in the near infrared, which is not commonly available in most African settings. Next slide. And we see, yes, indeed, with an infrared spectroscopy approach, we can obtain the same results in a shorter time. Both methods are interchangeable. So you here see the spectrum, which is clearly showing the glycation peak of the proteins. Next slide. And we see indeed that the chemical assay nicely corresponds with the spectroscopic assay in the infrared on the y-axis. Next slide. And this allowed us to prove that indeed the progress of the glycation goes from the deeper parts to the more superficial parts. So it's a diffusion that takes place from deeper to superficial layers. Next slide. And we see indeed that there is a difference in glycation amongst layers. Next slide. You see that clinically it's very easy to use the parameter. Here we see a comparison between non-diabetics on the left-hand side and diabetics on the right-hand side. So it's a distinct situation. Next slide. And this allows us to obtain very acceptable receiver operating characteristic curves. So it is usable for diagnosing diabetes in African patients. Next slide. We see that when we are grouping patients according to the presence or not of target organ damage, that we see, of course, that the more complicated cases tend to have higher values than non-complicated cases. So it is reflecting the severity of the diabetes as well. Next slide. Here we see the spectrum of the infrared, where we can see that there is a chemical modification in the nail. Next slide. But you see that it is very difficult for interpretation. It requires specialized software in the sense that you need principal component analysis. And from the complex spectrum at the left, you can come to a clear distinction of the green dots, which are the controls, and the blue dots, which are the patient, by applying principal component analysis. But this is far from practical, and you see that you only need a very small fraction of the spectrum. So here we need an expensive infrared spectrophotometer, and you are using the photometer also only to a very limited extent. Next slide. So we can reduce the spectrum to a couple of key wavelengths, and this allows us to dream about a more simple machine, because you don't need to construct an expensive infrared machine, but you could simplify the design by selecting a couple of commonly used wavelengths, in particular LEDs, which are used in the communication industry at a large scale nowadays. Next slide. And we could come to, you will see the evolution which you can follow using infrared. Yes, next slide. We can come to a more simple design. And that's what we do have in mind, is the development of a simpler machine, which is of course much cheaper and which could be clinically applicable. And there is, at the time being, a British company who is trying to bring such a machine on the market. So there is still evolution in this field. Next slide. So yes, this brings us to the conclusion that indeed fructosamine in fingernails can be considered as a suited alternative for diabetes diagnosis. Fingernail fragments can be easily obtained. You don't need to have a doctor or a nurse. Everybody equipped with a nail clipper can prelevate the sample. It is a very cheap method, and the stability of the sample is quite good. It can last for weeks and even for months, even at elevated ambient temperature, and it might even better reflect the true glycation of target organ proteins because it's measuring lysine-based glycation. Although we don't want to challenge current diagnostic criteria which are given by WHO, we don't want to make revolution. We do believe that we can offer an affordable alternative which is particularly suited for an African context. It goes without saying that not only Bukavu can profit from this research. This is, I think, the end, yes, of our presentation, and we are open to take your questions.
Yes, sorry, thank you both for the very interesting presentation of your research. And indeed, we would like to open the floor for questions. I saw that there were already some questions raised in the chat. So let me maybe start with the question in the chat. The first is a question asking, does this method also apply to young children with diabetes, and can they also be followed up with this method?
The answer is definitely yes, because children have nails just like adults have. Prelevating nails is not a painful experience, so you can it's definitely friendly towards children, and the interpretation is about the same. The rate of nail growth is comparable to the one in adults. So in other words, this is possible.
Yes,
Very
I
clear.
have all. Yes, sorry. I have also to mention that in the study we include also type 1 diabetes, and we could be we was able to follow them with this method, and we found good results.
Yeah. Here, I see that Paulos Pasha would like to raise a question, so feel free to unmute and to show your camera and address your question directly to the researchers.
Thank you so much. My name is Dr. Paulos. I'm a family physician in Swatini. Thank you for interesting presentation that you did. My question is, what makes it cheaper compared to HbA1c? Is it the reagent, or what made it cheaper? And also, at the same time, I want to know what made the HbA1c expensive compared to this. So where is the difference?
Yes.
If the outcome is, at the end of the day, the outcome is the same, then what makes it cheaper, this one?
Yes. So when measuring hemoglobin A1c, traditionally HPLC equipment, so chromatographic equipment, is used. This equipment can only be used economically when the series applied are large. So many European hospitals will run between 10 and 50,000 A1Cs a year. And for European hospitals, this would mean a reagent cost, let's say, of approximately €1 per test. When you would go to Africa, this is not applicable because the demand of A1C tests is too low to justify the installation of this type of equipment. So the only alternative for African labs is point-of-care machines. Point-of-care machines are characterized by an extremely expensive reagent cost because of the chromatographic cartridges that are used. These cartridges have a price, if you can buy them in large numbers, of about 7 to 8 euro per test without the instrument cost. So this means that on the African market, I think these tests are offered for prices between $15 and $25 per test, which means that it is out of reach for most African patients. Here we are dealing with reagents where the products can be bought in bulk. So you can buy the powder on the market of chemical products at a very cheap price. They can be produced locally, so the buffer solution which is needed is very cheap. So you can come to a price per test of, let's say, $5, $10 at maximum for one test. So that's a huge difference. When you have to pay $7 or $7 that's 2 orders of magnitude difference. So in other words, you can help 100 patients for the price of one. So I think this is a convincing reason to go for the approach which has been discussed during this podcast.
Thank you for your answer. I see that Mr. Augustin asked maybe a similar question, but Augustin, feel free to direct your question or to ask your question directly. Sir Augustin. Otherwise, I can initiate it. The question is related to he wants to know how this method contributes to public health, knowing that at least 60% of the population in South Kivu does not have direct access to quality health care. And so his concrete question is like, what are the performances in terms of durations to get the results, but also the cost, which was partially covered now, the intrinsic and extrinsic performance compared. So yeah, what is this methods contributing concretely to public health, especially
I think it's a better question for Professor Sikomola.
Yes. Of course, I think knowing the context of health system in my province, what I may say, it is first, Professor Delang shared the advantages of this method in terms of costs, as considering A1C, I know in Kavu it is around $20 per test. But if we use this test, it can be maybe 0.001 dollar. This is very acceptable for patient. The big question I can see here it is if the method can be easy to replicate for our nurses and healthcare professionals. I think yes, it is easy to learn. I am not a laboratory technician, but I try to by myself trying measuring this fructosamine using this method, and I learn it very easy. Also, the technician we work together in this project, they had just 30 minutes of training and they could be able to use a method. It's very easy. And in terms of public health system, this can be helpful for the system in the sense that we have just a big laboratory in South Kivu, but as you can see, this method can be replicated even in small laboratory in the remote area. That I think can be very helpful and useful for the for patient. But I cannot say that using this method will bring medicine to patient. No, but it's giving another. It will be helping patient and healthcare professional to follow and to treat and to diagnose patients suffering with diabetes. I see another question. Maybe no. Okay, it is you. It is not a question registered for me. Thank you.
Thank you for your answer. I also see that Mr. Maya Yakarasi has a question. Please go ahead.
Okay, thank you very much. Okay, so my name is Maja Jakaras. Thank you very much for this very good presentation, and maybe to try to situate myself before I ask this question. Yeah, issues to do with diabetes, especially in Africa, it's now an issue, and it has now reached almost every household in Africa. I'm basically from Zimbabwe, and I know, in fact, each and every household in the family is affected with this issue of diabetes. And I'm also doing a PhD in anthropology, medical anthropology. So I was so much interested when I see this presentation. And now my question, I think maybe before, the reason why I had to introduce myself is to locate myself as an anthropologist in this presentation, is to say, I have seen that you have said nails are easy, and from biological point of view, they are not that important. But see, I would even want to understand whether you have done a research, because from my own understanding, a human being from African point of view, each and every part of a human being is very important. It can be a nail. If my nails are very important, each and every part. In fact, it's a person is individual, meaning that is made up of a number of things. Of course, if you treat him as an individual, therefore you're just talking to an individual. But in an African context, is made up of a number of things, to the extent that even if it is my sweat on my clothes, I wouldn't want to give my clothes to someone, because I will be afraid to be bewitched by someone. These are realities. Then my question is, have you ever done a research maybe to understand how do they define nails in that African context from the Congo? How do they perceive? Because in many cases I've seen from experience that we know from Eurocentric perspective that, for instance, even from elites, that nails for me, they are not that important. But from ethnographic studies, you would even see that maybe what you thought maybe was going to be very cheap might be very expensive, in the sense that people would not be willing to give up their nails. They will say, no, there is a room for me to get. My blood was better than this one. Have you ever, maybe, if you have some comments maybe around those areas?
Yeah, I think this is a very, very nice question to address. What I can just say, we didn't try to look at this question, but for patients who came to me for the follow-up, they preferred at that time giving meds than giving blood, because the blood is painful, to take blood is painful, just for that. Maybe we can think about this question and look on what really patients think about giving their meds. We didn't address this question at that time. Also, the Professor Derang present what we are, the dream of the future. The next device we are developing will not need to give nails. It will be very easy. Just maybe if we could put again the picture. It's just put the hands, and we can be able to diagnose diabetes with the device without giving nails. And I think this can be, we can be able to address your question. If people are afraid for giving their nails, this new method can be a good alternative for that. Thank you.
Hello.
Yes, hello, Mr. Paulos. Go ahead, please.
Okay, thank you again for this interesting presentation. My question is, okay, it looks like this is the first of its kind, and how the acceptance and the approval at the international level? Is this something that is done in Congo only, or is this something that is now practiced somewhere else in the world. And then has it been approved by relevant organizations such as WHO and other very relevant organizations?
So the data which we have presented today have been published in various publications dealing with various aspects of the topic. So ranging from pure analytical findings, the colorimetric method, the infrared spectrophotometric method, to more fundamental issues, so the structure of the nail, and to clinical studies. So we have published clinical data on European and African patients. Also African neonates we have studied. So the scientific community has been able to read our work, and so far, if we look at the number of citations, we see that indeed our work has been cited. I think when you add up all our articles, we get so far about 50 citations. So definitely there are people that are trying to obtain similar findings. Of course, when looking at WHO, this is an ivory tower located in Geneva, which strictly adheres to its own criteria, which is glucose, hemoglobin A1C, and glucose tolerance testing. So far we haven't been able to get it widespread. Okay, but I do believe that these first results are encouraging, and also the fact that people are working on the development of a commercial instrument, spectroscopy based, is a good sign that indeed we are moving forward. Anyhow, the findings are public, and there is no patent on the chemical method. So everybody is free to start tomorrow obtaining the same results. So there is no IP hurdle that prevents people to do it. And neither the cost price should be a hurdle. It is much cheaper than competing methods. It is, I think, more the propagation of the findings. Maybe a drawback so far is that results mainly have been published in laboratory-oriented journals, and this has caused a situation that not everybody reading clinically oriented journals has been aware about the possibilities. But I'm an optimist, and I believe that it should spread, and that when more people would be convinced about the advantages, that it would definitely improve the situation.
Yeah, thank you for the clear answer. I'm afraid we came to the last question, and it's actually, I will consider them last question. There are a follow-up of what was raised before regarding the thresholds, maybe in some cases, to give nails. The question is, on one hand, are both nails of foot and hands usable for to get the results? And also, did you experience some reservations, especially from women, to give nails? And is there any issue if women have nail polish to, like, if is the nail still usable when there is nail polish on it? So those are the last questions.
Yes, nail polish is indeed an analytical problem. It prevents any spectral analysis. This is true. I've noticed another question on the foot nails.
For the foot,
This
yes.
is what we don't recommend usually, since there are often in diabetics trophical problems in the lower limbs, which could hamper the interpretation. That's why we prefer fingernails.
Okay, that's a short but very clear answer. I'm afraid we came to the end of this community talk. Firstly, I would like to thank the audience for attending this community talk. Thank you for your attention and participation in the Q&A. I would also, of course, like to thank the speakers and researchers, Professor Chikumola and Professor De Lange. I think you managed to give a very insightful presentation and to combine more theoretical explanation with the practical situation concretely in Bukavu or in Congo. So thank you very much for that. I surely enjoyed this community talk. I hope all of you did as well. And allow me to use this opportunity to invite you already for the community talk of next month of November 29th, where we discover a research project on improved poultry livestock in Kenya. So hope to see you all there. But for now, enjoy the rest of the day, and thank you again.